We move to the next panel discussion, molecular tumor board in breast cancer, and may I request Dr. Senthil Rajappa. May I request the panelists also to come to the stage, Dr. Mansi Khanderia, Dr. Prabhat Bhargav, Dr. Aparna Dhar, Dr. Gauhar Shafi, Dr. Lakshmi Priyadarshini, and Dr. Santosh Kumar Chellapuram.
Good morning, all of you. On popular demand, our panel has been cut down by 5 minutes. Okay, so we will stop in 25 minutes. Okay, there's the clock. So one request is that we'll run it like a rapid fire. Okay, I don't know the answers to any of the questions that I'm going to ask you. So you're okay to say whatever you want to say and then we'll pass it. Right? Lovely. So let's start with this case. 37-year-old lady, T4B N2, ER positive, PR negative. I hope all of you received the mail that I sent with these cases. I hope you didn't junk it straight away. It looked so terrible. Okay, chemotherapy followed by surgery. Germline BRCA was negative. Adjuvant radiotherapy, 3 months of leupride tamoxifen. 12 months later had neck pain. MRI showed a soft tissue, surgical decompression and fixation. Biopsy was again positive for ER, though a little lower than what it was earlier. Started on gemcitabine carboplatin, clinically well on leupride. Estrogen were castrate levels. So this is the profiling that came out from that cervical biopsy. So the PIK3CA is positive, FGFR1 amplified, FGFR2 amplified. Dr. Aparna, what's the implication of these things that we're seeing on this report?
All right, so FGFR amplifications are usually associated with endocrine therapy resistance and CDK4/6 inhibitor resistance.
Excellent.
So when we have a profile like this, you have a very classical PIK3CA mutation up there, the PH1047R. It's a targetable mutation. In a case like this, it may be worth considering PIK3CA inhibitor alpelisipir with maybe fulvestrant.
Excellent. Prabhat, PIK3CA mutation is there. FGFR1 tells you that it's going to be resistant to CDK4/6. What would be your first line therapy for this lady? Mike? Yeah.
Whether there was the only site of disease?
There were a couple of liver metastases and a couple of bone metastases.
But still in this case, considering MBC first line, I would add CDK4/6 inhibitor rather than directly jumping to alpelisib.
Santosh, agree with CDK4/6?
In this CDK4/6, the reason being is CDK4/6 located in nucleus below the level of PI3CA and FGFR.
So you're seeing the nucleus there?
In the mechanism
Oh, you're
of
talking
action,
about the cell?
Yeah.
I was wondering.
So
okay.
it's the final destination of CDK4/6.
Okay.
All these are above it.
Okay.
So we have a data that even in PI3CK, CDK4 works. So the toxicity of PI3CK inhibitor, considering all this, and we have data that even with PIK3CA, CDK4 works. So
okay.
Although less, so I would...
Okay, so the point is that the presence or absence of a PIK3CA mutation should not determine what you do in the first line. Your algorithm will continue to be fulvestrant or letrozole plus a CDK4/6 inhibitor. So that's the most important point here. Right? So don't get carried away when you see a PIK3CA. What's the implication, Dr. Mansi, yes, what's the implication of that FGFR? Should we act upon it some point in time? Should we not?
So again, we don't have FGFR targeted therapies for breast cancer, but because of the PIK3, I have two options which I would discuss with my patient. One is continue fulvestrant with CDK4/6 alone, or just to add that little bit of extra for the FGFR, maybe add everolimus, but it's a poorly tolerated drug.
Okay, what made you think FGFR and everolimus?
There is some studies which I have written, especially in cell lines, everolimus has been, and we have some studies on regorafenib, but I saw that everolimus is possibly a better way to get over the resistance, the hormone resistance that we have with FGFR.
Okay, lovely. So that's a very important point. So FGFR also seems to be acting through the mTOR pathway. So
Yes,
that's where
yes,
that
yes.
everolimus comes from. So everolimus is something that we need to think about. So, when would you do that everolimus? Would you add it with the CDK4/6 or would you do it a little later at some point in time?
Possibly later, but if the patient is, so this patient is young. If I had a very old patient, I would definitely put it out for later, leave it for later. But if it is a young patient, I would definitely ask her to keep a close watch. If we do see that CDK4/6 is not really working in 3 months, then I would immediately add everolimus.
Keep the
after
fulvestrant and
3
add the
months.
everolimus and see what happens.
Yes.
Or would you do PIK3CA alpelisib?
No, I would say CDK4/6 with fulvestrant with everolimus is what I would try if the first two are not working. I would not switch to alpelisib because it's not a very...
It's a painful drug.
Yes, I would not be very happy with
Okay,
that.
lovely.
Everolimus
So-
is better than that, and imagine if I say that, how bad would that be?
Everolimus is better than that. So,
Can I ask a question?
Oh,
Since
please.
it is an FGFR amplification, why not something like lenvatinib, which is a multi-kinase inhibitor, where there
okay,
is
so there is,
sufficient
that's
data?
why I put up this because I hope, yeah, it's there on your screen. So this is, so whenever I have a problem finding out the significance of a mutation, this is what I do. I go to OncoKB. I like it because it's easy for me to go through. And this is what OncoKB says as far as FGFR amplifications are concerned. In fact, FGFR1, there's no amplification annotated in OncoKB at all. Okay, so that's as rare as it can be in breast cancer at least. But there's some data on FGFR2 amplification, and there are some studies, small studies in gastric and breast cancer saying futibatinib might be a drug. So where do we go and get futibatinib? You can't. So yes. So the problem always, yes, Santosh, you want to make a point?
Sir,
Yeah, please.
I've just, after you sent the slides, I've reviewed this amplification and all.
Excellent.
So what I studied is this amplification is not targetable. If we find a mutation,
Exactly.
possibly that could be targeted, but amplification, I couldn't find strong data.
That's why it's not even annotated, at least the FGFR one. So the point here is the presence of PIK3CA should not change your algorithm. You always tend to sway on the side of the molecular report, but I don't think there should be an itch to act on everything that you see on that report. Please be prudent when you interpret it and decide on what you want to act, because Dr. Mansi spoke about both everolimus and alpelisib. Both are not easy drugs to handle. It can be very difficult for patients and doctors. So just be sure that you want to do it before you really did it. At some point in time, you may want to think that this FGFR is significant and throw in that lenvatinib or cabozantinib, but you really don't know when, right? Because you've got a lot of standard options that you can use in these patients, and by the time you exhaust all these standard options, the molecular biologist will say, do another biopsy, and then we think about what is to be done.
I would
Okay?
I would keep FGFR right for the end. That's what I
Right
would tell
for
our
the end.
medoncs.
Right, just like Santosh said, since it's not druggable, at least
upfront.
in breast cancer, we will not give much credence to it. So don't change your algorithm. So that's the lesson from this patient. 60-year-old lady, breast cancer with bone and lung metastasis, letrozole palbociclib 16 months, progressive disease, breast and few lung and bone mets. She was started on fulvestrant, and this is the report that you get. The ESR1 is mutated, and it's a somatic BRCA2 mutation. Dr. Shafiq, your thoughts on this report?
Yeah, so this BRCA2 mutation is important here.
Okay.
And I would also like to see, whether this BRCA2 mutation leads to HRD deficiency.
HRD, okay, we'll come to that in a moment.
Yeah.
Okay, so you want to do HRD testing and then decide on what is to be done with that, or you're happy with just seeing a BRCA2 somatic mutation?
No, I think we should do the HRD to know that whether it leads to the deficiency.
Okay.
Because all BRCA mutation does not lead to the...
Almost all would, right? Almost all would, I said. The percentage of BRCA mutation which don't end up in a HRD is about 1.5%.
Yes. So we
So
have to...
if the HRD is negative, you would think that this is not significant?
So then in that case, I would see if the patient has been treated with platinum-based treatment, and if
Okay.
it has responded, and then in that case, possibly it would...
Okay, a simpler way of doing things, I suppose. Dr. Lakshmi, what would you do in a patient like this? So we've started this patient on fulvestrant. The question is, okay, we've taken care of that ESR1 mutation. We'll not discuss about LSS trend for a moment. Okay, that's a little complicated. So we've done fulvestrant, which is typically what we would do with the drugs that we have. If we find somebody with an ESR1 mutation, would you act on the BRCA2? You would not act on the BRCA2. Both the molecular biologists are a little hesitant on acting on the BRCA2. We'll come to them in a moment. So would you act now, later? Never.
Sir, I will continue fulvestrant.
Okay, mic closer.
I will continue fulvestrant,
Okay.
sir. And in further lines, I will try to act on BRCA mutation. But as of now, I will continue fulvestrant only.
You will continue fulvestrant
Yes, sir.
only. PFS is 3 months, Bhuvan showed us. So you're already getting ready for the next drug. Okay, never mind. It's okay. Perfectly all right to do fulvestrant. Mansi, you want to say something? And then Prabhat, Santosh.
I would send germline BRCA in the
Germline is
meanwhile.
negative.
It's negative?
Yeah, it's
Oh,
negative.
okay.
I added this point later on the slide.
So,
yeah.
so then I would continue fulvestrant and then maybe prep her for a platinum-based chemotherapy once that stops working.
Both of you, would you prefer platinum-based chemotherapy to a BRCA-targeted therapy? Lakshmi, yes, you can take it, or Santosh, Prabhat?
Sir, this is a hormone positive. In principle, I'll treat as hormone positive. After fulvestrant, everolimus, exemestane, we will try. Later, I would think about adding chemotherapy when.
So you're not interested in targeting this BRCA2 at all?
Not now.
Very interesting. Okay. Any specific reasons you think that's not pathogenic?
Sir, it's pathogenic, but I feel that single agent olaparib or talazoparib as a single agent would not give a good thing. That would be given by everolimus, exemestane.
So let's say if this was a germline, what would you have done?
Germline also, I would like to give everolimus, exemestane followed by.
So everolimus, exemestane, the response rate is in single digits. BRCA-targeted therapy for a germline BRCA2 is about 65%. The PFS is about 3.5 months for exemestane, everolimus. It's about 7.5 months for either olaparib or talazoparib, based on whether it's a talapro or whatever those two studies are, the Olympiad and the talazoparib study. So we are seeing vastly big responses, cross-comparison, doubling of PFS. Why is it that we are hesitant? I'm just asking why. Because I did use olaparib and then we had some lovely responses. So, Prabhat, you also said you would want to delay it. Any specific reasons you want to delay it?
In this case, even I will delay. I will use fulvestrant first and then.
Okay. And you would use platinum-based chemotherapy rather than, just a moment. You would use platinum-based chemotherapy rather than olaparib.
No. I will also, if not in visceral crisis, I will give, if after fulvestrant still not in visceral crisis as now, I will give olaparib. I have a time to try olaparib.
Okay.
And if in visceral crisis,
Okay. So
I
you
am
will use it.
nothing standard as you start in between.
Lovely.
I will use
quick
that.
point.
Not add olaparib to fulvestrant.
Super question. In fact, that's what I also wanted to ask. Mansi, why not add olaparib? It's not cross-resistant in terms of its toxicities. Good time to try something, because we are not very confident about doing what we are doing. So Amish is absolutely right. Practical point. Why don't you add it right away?
I would let fulvestrant work for as long as it's working and then
14% response rates, 3.5 months PFS.
3 to 5 months.
You're still happy with that?
And
Okay.
then add
Amish,
olaparib,
go.
and then we had some data presented by Dr. Bhuvan that in PARP maybe use olaparib before chemo when it is coexistent. So that depending on visceral crisis,
So we are in a molecular era, and then we should use the targeted therapies rather than good old chemotherapy, right?
depending on the visceral crisis, I would still
So does PARP inhibitor take a long time to start working?
not so
Not
much.
really, right?
Not
So these are some things that we've
But
got into our...
we are also comfortable with platinum drugs.
Okay, so we are more comfortable with platinum compared to the PARP inhibitor, so we are preferring that. So this is again OncoKB showing you where BRCA2 is. So it actually says there is promising clinical activity with olaparib. I think this is a little not recently annotated, I would say, and these are the response rates that you get. The biggest study is showing you a 50% response rate with a PFS of nearly 6-7 months. So there are other studies which are showing that it's not great, but if you extrapolate from ovarian cancer, the responses to germline or tumor, somatic BRCA, don't seem to be very different in terms of the responses and the PFS and so on and so forth. HRD in breast cancer is a little shaky still. We don't do HRD we don't think it is a tumor agnostic way of treating so far. HRD can be very widely different in terms of the cutoff scores that we use. We are still struggling with endometrial cancer. That's the next thing that's knocking at your doors as far as HRD is concerned. We just don't know what the score should be. We don't know what the method should be. We don't have prospective data to say that HRD is a great thing, but it's a good thought that doing the HRD might actually add on and then say, or increase your conviction to use a PARP inhibitor in a patient like this, but that's not something that we would routinely do. So for that patient, it's important to take that somatic BRCA into consideration to do some BRCA targeted therapy at some point in time, which is typically a PARP inhibitor or platinum-based chemotherapy. I don't see a big difference in terms of time to response, whether it's platinum or PARP inhibitor, but it's absolutely fine to say that if you've got lots of disease, you want rapid responses, it's okay to go with the platinum in a situation like that. Otherwise, it's perfectly all right to use a BRCA. I, in fact, agree with Amish's thought that if you're not too sure about the usage of a targeted therapy, use it at a time when you can test it. You're not in any hurry to get your responses. You know, that's what I do in reality. If I don't know what to do with that, and it's a targeted therapy that I can access, I most of the time use it as maintenance therapy. You know, stop that chemo and put your patient on that. It's a good testing time. You also learn. Yes, Amish, quick point.
Metastatic disease in breast cancer, we have proven that chemo-naive patient olaparib works longer.
So the earlier the better.
Earlier the better.
No,
I can't.
that's what
but
they
I can't
say.
understand
That-
that.
But whether the
No, that's okay.
combination
That's okay. They have their point. It's okay. I mean, everybody should get the confidence to get onto a targeted therapy rather than platinum. Platinum is cheap, simple, easy, not very toxic for our patients. So I don't think it's a wrong choice at all. It's an absolutely good choice to use in our patients. So that's what it is. So if you find a somatic BRCA, it is a druggable alteration. We don't have to do anything further to check whether it's druggable or not. You don't have to, you do the germline, but irrespective of the germline, you still do it because the responses seem to be good. Excellent. So we've got 9 minutes to go. 71-year-old diabetic, carcinoma left breast, T3N1 MRM ERPR positive, refused any chemotherapy. She had radiation therapy followed by letrozole. She had a left internal mammary recurrence after 1 year. Surgery was done, that was excised. The ER and PR dropped significantly to 20 and 10%. HER2 was negative. She had radiation to that area. And this time she agreed to get some weekly Taxol, and then that was followed by tamoxifen. 2 years she was fine on tamoxifen, and then she gets multiple right supraclavicular lymph nodes. A biopsy was done. GATA was positive. It's a triple negative cancer now. There's no primary in the right breast, both on the PET, MRI, and a mammogram, 3D mammogram. She refused surgery for the supraclavicular area that was suggested to her and radiation therapy. So she's got these multiple supraclavicular lymph nodes now. She's a diabetic on 2 drugs. Her SbA1c is 6.4. Dr. Aparna? PIK3CA, FGFR1, we won't discuss the FGFR, we've already decided it's not druggable. We'll discuss about the AR, I think that's the reason that I put up this patient. So can you tell us about the role of AR, and as a molecular biologist, how would you interpret this?
So it is a triple negative breast cancer
Yes,
now,
it is
right?
triple
so
negative
an AR is a significantly sufficient copy number to say that this could be potentially an AR-driven tumor.
What's your general cutoff?
So 6.
6 is your general
Six
cutoff?
is my
Okay,
cutoff.
okay.
So at 9 copies, I would be a little comfortable saying that, yeah, this could be a potentially AR-driven tumor. However, what's really standing out for me over here are 2-3 things. One is the PIK3CA, I'm going to ignore it in this particular case. It's triple negative now. And in breast cancers in general, 30 to 40% are going to have PIK3CA. So I'm not going to even look at that PIK3CA tumor mutation at this point. What's of interest to me is that you have an ATRX. It's not actionable, but it's part of the homologous recombination repair pathway, which kind of confers to the fact that your tumor will be platinum sensitive. Secondly, if you come down, there is a Richter amplification. Again, this is part of the homologous recombination pathway. So when I look at this report, it's not a very straightforward, actionable report, but it does tell me that this is a more platinum-sensitive tumor versus, so that would be my takeaway from this at this particular point. Would I act on the AR? Not now. I would maybe treat, my recommendation would be more chemo at this point.
So you want to do the chemo now. Santosh, chemo now for a for supraclavicular lymph nodes in a 71-year-old lady?
No, with the amplification of 9 copies, I would go with the AR with enzalutamide.
You would go with enzalutamide. Dr. Lakshmi, you would also go with enzalutamide?
No, sir, I want to give chemo to this patient.
You want to give chemo to this patient. Any specific reason you want to do chemo?
So, triple negative, and she is having supraclavicular active disease is there. And though she is having AR positivity, but there are no clear-cut guidelines for AR targeting therapy.
Excellent, very good.
So I would like to give her, based on diabetic status and all, chemotherapy.
Okay, you want to
NAP, Paclitaxel, and carbolate.
Okay, so Prabhat, the question is, should we confirm this with some immunohistochemistry first? Because all the studies that have looked at enzalutamide, apalutamide, any lutamide is being on IHC. It's not based on what we are seeing on your screen. So would you think that it's good to go back, get that tissue and do some immunohistochemistry and look at what the percentage positivity is? Would you think that is worthwhile doing?
Yes, sir. I
Very
would
good.
do IHC and I would give carboplatin first, followed by your strategy as
My
maintenance
strategy, very
of,
good. I've convinced you that when you don't know what to do,
enzalutamide.
do it in maintenance. Excellent. No, that's a practical point. Okay, so guys, it's important to go and check this with immunohistochemistry. Many times you will need another orthogonal technique. You know, that's what the molecular biologist will use. It's called an orthogonal technique, so that you make sure that what you're seeing on the molecular is what it is on another technique also. This is something that we also do for HER2 very frequently, especially in other anatomical subsites. So, but the challenge with doing immunohistochemistry for AR is that there's no clear cutoff, whether it's more than 10%, whether it's 1%, what antibody to use, what platform to use, nothing is standardized, though we all keep off talking about AR targeted therapy in triple negative cancers. In fact, some labs routinely do ER/PR, HER2 and AR for all patients. Remember that AR can also be overexpressed in patients with ER positive cancer. The prognostic value may be a little different, but it's also positive. It can also be positive in ER positive cancers. But the challenge is that with none of the AR targeted therapies, you really found good responses. The responses over the board for enzalutamide. Yeah, Prabhat, you want to talk about it? Please go ahead. Please go ahead.
Yes, sir.
Tell us about the data regarding
Response
AR
rates are
targeted.
only 10% and PFS is also roughly 3 months in later lines. So I don't know what will happen in front line, but it is not there, so I wanted to use your technique of...
Excellent. So he's absolutely right when he said that the responses are around 10%. Okay, it's not that wonder drug. When you see this, it's not like letrozole in ER positive disease. Enzalutamide in AR positive disease gives you 10%, 15% responses, and then those responses are very ill sustained. So Prabhat is kind of echoing my thoughts that in a patient like this, we would probably treat with something that is more time tested and then use this as maintenance therapy rather than not. Santosh, Dr. Aparna spoke about PARP inhibitor at some point in time because of Richter and ATRX. What are your thoughts?
I said platinum, I didn't say PARP.
Oh, okay. Why not PARP? Okay. Mansi, why not PARP? Amish wants to ask that question.
We don't have. So just because
can
something's
do a
part
HRT
in the, just because it's part of the pathway, we can't always just consider and say, yeah, a PARP will work. In a case like this, when we do know it's platinum sensitive, it is the homologous recombination pathway that's activated. What we have learned, because we have been burnt in the past, in a case like this, we now do an HRD test. If that HRD test, yes, the score varies, so we're still not very sure, but if something says that, yes, it's high, in a case like that, then we'd be a little comfortable to say there is genomic instability, which is established. In a case like that, yes, I can consider a PARP inhibitor. We have tried with something similar in our breast cancer triple negative, where the homologous recombination pathway is activated. We've given a PARP inhibitor, and we've not had the response that we're looking for. So for us, the thing is that we do know this is going to work. Check for genomic instability, and then it becomes, we get
Amish,
a better response.
Quick comment, Amish.
So ATRX and Richter both tell me that it is actually the repair pathway is already damaged, and that's why the PARP inhibitor can be thought of in this patient.
So, Santosh, let's say you find an ATM, let's say you find a BAP1, let's say you find a BRIP1. would you use a PARP inhibitor, or you would say, no, these are just HRR mutations, I would not use PARP? What are your thoughts on that?
Yes, in regard to ATM, BRIP and all, I would like to check even HRD. What is the phenotype they have produced? Mere presence of that would not act me to give some agent directing it. Maybe see the actual phenotype by HRD. If the score is significant, then yes.
What HRD assay?
So I would do the myriad HRD.
You would do the myriad HRD assay. Any thoughts on functional HRD assays, looking at RAD51C protein by immunofluorescence? It's called some functional HRD assay that people are starting to do. Excellent. Okay, no problem. So again, for you, HRR mutations do not give you sensitivity to PARP inhibitors. Please remember this. Okay? ATM, BAP, BRIP, PALB2. In fact, in the short study or small study that was published a few years ago, the only other mutation that gave responses apart from somatic BRCA was PALB2. Everything else turned out to be a cropper. Okay, so this is now shown clearly in prostate cancer. This is now clearly shown in ovarian cancer. So please remember that having a HRR mutation does not tell you that your tumor is likely to be sensitive to a PARP inhibitor. HRD is a very intuitive thought, but as I said earlier, HRD is again not standardized in any other disease except ovarian cancer. Please don't go home with the thought that HRD is a tissue agnostic marker. No, it is not tissue agnostic. There are situations in other tumors where HRD score is high, but you don't find a response to PARP inhibitors. So again, these are not interchangeable. So common sense, good old platinum is what we would be using if you decided to do chemo. Again, don't need to go chasing this report just because it's showing you many alterations. So for me, don't forget your regular algorithm that you would routinely use. And the decision-making point should always be, I'm done in 10 seconds. The decision-making point always should be, you have another competitor therapy here. You've got your standard therapy here. Is your competitor therapy better than the standard therapy in terms of either efficacy or toxicity with at least equivalent efficacy? If that question is asked and you have an affirmative to use your targeted therapy, go ahead and use it. Otherwise, please use your regular algorithm to manage most of these patients, and that's the way we should be treating our patients. Thank you so much. Thank you so much, panelists, and I hope you enjoyed and learned a bit.